Apa tuh DJ bunyi di sini. Coba ikut tes testing.
Assalamualaikum warahmatullahi wabarakatuh. Testing, testing, check one, two. Testing, testing, check one, two.
Boleh kan? Boleh? Boleh. Pointer boleh, nak boleh.
Maksudnya kalau pointer tu okey.
Okay, Ija.
Nah,
Ini.
so untuk yang ini hot ni slide hot letters
Later dah, saya beramah ni je kalau depan.
Dia sedang hot N je tadi bagi tak dia. Ini tak tahu habis. Oh. Tak tengok ni je ada. Tak apa. Saya nak tengok hot ni ada tu. Deh. So kalau next slide tu hot ni.
Okay.
Thank you, thank you.
Tuan-tuan dan puan-puan, sesi ini kita akan bermula sebentar lagi. Mohon semua mengambil tempat duduk. Mohon kerjasama untuk memenuhkan tempat duduk kosong di bahagian hadapan dahulu dan pastikan telefon bilik anda berada dalam mod senyap. Untuk kehadiran, sila imbas kod QR yang dipaparkan di skrin. Kod QR juga tersedia di kedua-dua sisi dinding dan pintu auditorium. Terima kasih. Tuan-tuan dan puan-puan, jadi kita akan bermula sebentar lagi. Mohon semua di tempat duduk. Mohon kerjasama untuk memenuhkan tempat duduk kosong di hadapan dulu dan pastikan telefon bilik anda berada dalam maksimal. Untuk kehadiran, sila imbas kod QR yang dipaparkan di skrin di hadapan. Kod QR juga tersedia di kedua-dua sisi dinding dan pintu auditorium. Terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. Dan selamat pagi kepada para tetamu hormat kita, Dr. Putri Nurbaya binti Muhammad Ismail, Timbalan Pengarah Perubatan 1 Hrpz, Ketua Jabatan, pakar-pakar dan pegawai perubatan, para medik dan seluruh kaki tangan Hrpz yang dihormati. Pertama kali, saya ingin mengucapkan ribuan terima kasih kepada semua kerana meluangkan masa menghadiri sesi seminar kita pada pagi ini. Saya, Dr. Muhammad Syafiq daripada Jabatan Pembedahan, akan menjadi pengacara majlis anda pada hari ini. Tanpa melengahkan masa, saya ingin menjemput Dr. Siti Fatimah binti Ismail, pakar perubatan kecemasan dan trauma, untuk menyampaikan CME kita pada hari ini yang bertajuk Behind the Green Curtain, Revealing the Dark Side. Dengan segala hormatnya, dipersilakan.
Yes, Assalamualaikum warahmatullahi wabarakatuh. Everybody, good morning. Thank you, Mr. Chairperson. And a very good morning to Honorable Dr. Putri Nurbaya, Deputy Director of Medical Affairs, Hrpz, to Dr. Razak, Head of Emergency and Trauma Service in Kelantan, and Dr. Wan Rashdan Wan Abdullah, Head of Emergency Department, consultant, specialist, medical officer, paramedics, and all respected staff of Hrpz. I'm Dr. Siti Fatimah binti Ismail, representative from Emergency and Trauma Hrpz. Today, I would like to present a hospital CME entitled Behind the Green Curtain, Revealing the Dark Side. So before I proceed to what I want to discuss about the green curtain, I would like to share with you all the case scenario that relate to this. In my patient's 1MA, 39 years old, was visited to emergency department on the 18th January at around 9 p.m. and was discharged 6 days after admissions. And at the emergency department, patient complained of alleged injection of chemical powder around 30 minutes before presentation to the emergency, which is around 8:30 p.m. On the same day, it was preceded with physical altercation with the husband. Under stress, patient went to kitchen and then took the half pump of the chemical powder, which blue color, and then patient ingested it. Post-injection, patient complained of abdominal pain and also vomiting. Otherwise, patient denied chest pain, no shortness of breath, and no diarrhea. This is the chemical powder. This is the chemical powder that patient took. However, this sample was brought by husband later, after we already did the management on the patients. And upon arrival at emergency, patients alert, however restless with tachypnea and tachycardia. Patient noted as copious secretion in the oral cavity and diaphoresis or profuse sweating over the chest, back, and axilla. The BP was normotensive. The pulse rate was tachycardic. The temperature was afebrile. The RR was tachypneic with the SpO2 85% under room air. The glucometer was normal glycemia. So from the physical examination from the head to toes, we can see the pupils was pinpoint and the lungs equal air entry but no bronchi. CVS S1S2 normal, abdomen soft non-pedal, and no external injury seen. Then because of the patients said that patients took the chemical powder that used for pesticide or insecticide to eliminate the insect in the house with the cholinergic symptoms. So we treat this patient with alleged organophosphate poisoning with cholinergic effect. At the same time, patient had domestic violence with the husband and acute disorder with suicidal attempt. For the third impression, because at this time we cannot get the further psychosocial history from the patients yet. So this patient at emergency, we intubated this patient in view of this patient had airway compromise with evidence by patient had copious secretion in the oral and patient tachypnea and hypoxia. So patient was intubated. Post-intubation, in view of patient we are treating this patient with organophosphate, we give the antidotes which was IV atropine, and IV atropine we give first it started with 1 mg and double up the dose up to 60 mg. And then we continued with IV atropine infusion The IV atropine infusion is recalculated with 10% from the total dose of the atropine bolus and then give over 24 to 40 hours. And IV pyridoxine is the second antidote for organophosphate, and we give at the same time at the emergency for the antidotes of organophosphate. And because of domestic violence, we also activated the OSCC at the emergency level. So this is the investigation of the patient. As you can see, the full blood count showed leukocytosis. However, the HP and also platelet was normal. For the renal function, liver function, coagulation function was normal within normal range. UPT was negative, and ABT post intubation, it showed respiratory alkalosis, which is pH 7.5, PCO2 25 with good oxygenation, PO2 238, and then mild metabolic acidosis. So after insertion of the RAS tube, we can see there was a blue vomitus from the gastric content, which means that patient has ingested the chemical powder and manifested as poisoning effect. So post intubation, we did the chest X-ray, and the chest X-ray you can see the EDT is inside too, and then there was a prominent perihydrangiosis. And also we can see at this area, at the peripheral, we can see the reticulonodular opacities with suggestive of possible of chemical pneumonitis. Then the ECG done showed only sinus rhythm with no evidence of ischemia and also arrhythmia that can cause effect from the poison. And patient was referred to emergency. Patient was referred to medical and also administrative team. So patient was admitted to ICU and was extubated on the next day. Only 1 day for intubations. No episode of desaturation under nasal bronch. However, in ICU noted there was a moderate yellowish secretion during suctioning, and then patient was covered with chest infection with IV augmentin. And then patient able to transfer out to ward, a general medical ward after 4 days of admission in ICU. So in medical ward, after 5 days of injection of pesticide, patient complained of double vision. And then was referred to ophthalmology and OSCC team, which include the psychiatry and GTSP, also reviewed this patient in medical ward. So the ophthalm input was transient mydriasis, possible secondary to OP poisoning, and was given TCA under ophthalm for 2 weeks. And then for the psychiatry input, patient was treated as persistent depressive disorder with suicidal attempt and was started with FFRI, which is that sertraline, 50 mg or night, and was given this in psychiatry 2 weeks. So after I go through the secondary input, patients actually already under domestic and having domestic violence and social and financial problem with the husband for the past 10 years. And patient also already had a trial of suicidal attempt for 3 times. Okay, before discharge, the medical consulted Pusat Raja Negara, and the plan from them is to monitor symptoms for 24 hours. If no symptoms after 24 hours, may discharge, and no specific guideline after 24 hours. So patient was discharged. Patient was discharged well on 23rd January this year. Okay, this is the summary of the blood investigation since patient admitted until discharge. So we can see there is no target organ damage that can be seen in full blood count, renal function test, liver function test, as well as coagulation profile. And the chest X-ray also repeated before discharge. We can see the clearance of the perihydrangiosis and clearance of the bilateral lung field. Okay, from this case, what I want to discuss today is the pesticide poisoning. So why I choose the cream curtain is actually the pesticide is used to eliminate or to kill the pest from the crops, and it widely used in agriculture industry. So under pesticide, it's may divided further into many classes, which are consists of rodenticide, herbicide, fungicide, algicide, insecticide, and larvicide. For my patient herself, took insecticide while patients under stress at home previously. So under insecticide, it has further divided under it has 4 types, which are organophosphate, carbamates, pyrethroid or pyrethroid, and others. And most common injection of insecticide among the poison cases are organophosphate and carbamates. Okay, we go for the epidemiology first. This is the study published in 2020, and I got this from the Pusat Raja Negara also for the data. So this they stated that from the study about 11,000 pesticide poisoning cases were recorded, and 60% of them is intentionally cases. And from the pesticide types, the most common poison is insect, the herbicide accounted about 44%, agriculture insecticide 34%, rodenticide 9.9%, and last one is household insecticide is 9.5%. So means that this indicates that the pesticide poisoning is prevalent public health problem. Okay, next is about Berita Harian reported that in 2024, the Pusat Raja Negara received around 3,000 calls for poisoning case, and then it has increased from 2022 to 2023. It is a red flag for us, and this case is usually occur at the west coast compared to the east coast. And then when we are going to discuss about the pesticide or insecticide poisoning, and specifically is organophosphate and carbamates, I would like to discuss the basic physiology in the neuromuscular junction, because this is important because the mode of action of organophosphate is happened here. Okay, we can say this is presynaptic cleft. This is presynaptic neuron. This is synaptic cleft and postsynaptic neuron. So we can see the acetylcholine is formed at the presynaptic from the acetylcholine combined with choline and forming the acetylcholine. And then acetylcholine will release into synaptic cleft and then will activate or will bind to muscarinic receptor and also nicotinic receptor to stimulate the postsynaptic neuron. So, to balance the mechanism, the acetylcholinesterase will hydrolyze into the choline and acetate to prevent the overstimulation of the receptor. So, as you can see for the second diagram, we can see the nervous system that involved. All this nervous system has acetylcholine as a neurotransmitter to activate it. For such as for somatic skeletal muscle, and it has a nicotinic receptor. And then for the sympathetic, it has preganglionic acetylcholine as a neurotransmitter to activate. Parasympathetic, it also has acetylcholine as well as adrenomedulla. So from this, what organophosphate and carbamate do in this pathophysiology is the organophosphate will bind into acetylcholinesterase. So once it binds into acetylcholinesterase, it can cause inhibition of the enzyme and causing the accumulation of the acetylcholine in the synaptic gland. Thus, it will overstimulate the muscarinic and nicotinic receptors. So what happened? So if the excessive of acetylcholine happen in our nervous system, so at the central nervous system, which is more on the brain, it can cause headache, confusion, seizure, and coma. For the peripheral, it further divided into autonomic and somatic. As we know, the autonomic has sympathetic and also parasympathetic. For the sympathetic, the nicotinic the acetylcholine can cause migrasis, tachycardia, and hypertension. For the parasympathetic, it will cause the increase in secretion in our body. It started from the patient have increase in salivation, diaphoresis, emesis, diarrhea, and it can cause the increase in secretion in the body. And lastly is somatic. For the somatic, it will activate the nicotinic receptor and produce the fasciculation, weakness, and plastic paralysis. Okay, there are many symptoms that cause the cholinergic effect. So how we usually memorize or remember how the manifestation of the organophosphate is based on the receptors. Okay, the receptors for the muscarinic, the mnemonic used is dumbbells. So what stands for dumbbells is excessive defecation or diarrhea or and diaphoresis, U for urination, and for meiosis, which is pinpoint pupils. 3B, which is consists of bradycardia, bronchospasm, and bronchuria. E for emesis or vomiting. And then L for lacrimation, excessive tears, and also salivations. So for the nicotinic manifestations, they can be memorized by Monday, Tuesday, Wednesday, Thursday, and Friday, which is Monday is migrasis, the dilatations of the pupils. tachycardia, weakness, hypertension, and also fasciculation. So back to our patient just now, the patient has diuresis, salivations, we can manifest it as muscarinic presentation. However, patient had tachycardia, which may manifest it as nicotinic. At the same time, patient also had hypoxic at that time. Okay, we go to co-pharmacokinetic. So pharmacokinetic of the agents of organophosphate and carbamate is easily absorbed in the GI system, which is from the ingestion. The second one is can easily absorb through the inhalation and also skin and conjunctiva. So before for management of the organophosphate poisoning itself, we need to wearing the proper PPE to prevent the secondary poison. And then for the metabolites, the organophosphate will metabolize in the liver into inactive form. And then for the onset of toxicity, it depends on the agent, types of agent, the routes and also extent of exposure. Okay, just now I just explained about the acute toxicity of the organophosphate. So there are another three types of the classification or manifestation of the organophosphate because of depends on the onset of toxicities. So this the difference are first is intermediate toxicity, which is the symptoms is occur after 24 to 96 hours after exposure. So like my patient just now, patients complain of double visions after 5 days of injection. So means that patient possible having intermediate toxicity. The symptoms include proximal muscle weakness, cranial nerve palsy, and also respiratory insufficiency. The second is delayed toxicity. The delayed toxicity is usually rare and it occurs 2 to 3 weeks after exposure. And the symptoms also vague about stalking nerve paresthesia, cramping, and flaccid paralysis. So the second one is chronic toxicity, which it is occur after long-term exposure. Usually it occurs in agriculture workers. And presentation, patient may present with neuropsychiatric deficit, confusion, memory impairment, psychosis, or Parkinson-like disease. Okay, this is the important part in managing the patient, poison patient. So we have five steps to manage the poison patient. The first one is resuscitation and self-protection. The second one is recognition of agent. The third one is assess the severity. The fourth one is specific treatment, and the fifth one is to prevent the recurrence. Okay, for the resuscitation and self-protection, at emergency department, we need to approach the patient, or we usually approach the patient by ABC, which is airway, breathing, circulations, and disability. However, in poisoning cases, the first step is to prevent the secondary effect, secondary poison. So we need to wear the proper PPE. So the proper PPE is at least level D, which is consists of mask, apron, and also the glove. So because as we know that the organophosphate is well absorbed through the skin. So after we touch the patient, it is easy for us to get the effect of the poisons too. And then after wearing the PPE, so we approach by airway. So airway in poison, we need to anticipate the airway compromise, which is the complication from the side effect of the poisoning. And then at the same time, we need to look for any evidence of secretion and need to do frequent suctioning to prevent aspiration. The second, okay, if we want to intubate the patients, we advise or we preferable to use the non-devarizing agent in organophosphate poisoning. Why? Because devarizing agents such as choline, it metabolizes through acetylcholinesterase. So once we give the choline in before intubation, it can cause prolonged effect because the choline cannot be metabolized by the acetylcholinesterase. So for the breathing, so we need to look and assess the patient's ventilations. So look for the patient's respiratory rate, patient breathing effort, and patient any evidence of respiratory weakness that caused by the poison. So and then keep the SpO2 more than 95%. If patient having bronchospasm, so we need to treat that accordingly by giving bronchodilator and so on. And then the third one is circulation. So circulation, some of the poison agents and OP also, some of the OP agent also can have the cardiovascular effect, which cause the hypotension. So if the patient presented with hypotension, as the first rule is we need to assess the patient's fluid status. So if fluid deficit, so we can give the adequate fluid resuscitation by frequent hemodynamic monitoring. So after give the adequate fluid resuscitation, if the patient still BP low, so we need to consider vasopressor, and also inotropic support. Okay, next is disability. For disability, usually focus on neurological examination. For neurological examination, because it's of GCS of the patients, the pupils, also, and also presentation of seizure. So for the GCS, we look the patients alert and conscious, and also for the pupils, because we want to look the size of the pupils. Usually the poison can cause mydriasis and also meiosis. So like in OP, it can presented with mydriasis or meiosis. And then for the seizure, if patient come with seizure in poisoning cases, we need to give diazepam to terminate the seizure activity. And the last one is external decontamination. I will explain more at the specific treatment. Okay, this is the PPE. The PPE in the poisoning, in handling the poison case, at least is level D. For the level A, B, C is usually used in CBRNE disaster. So next, recognition of agents. How we, after patients come with suspected poisoning, how we approach is to get what patients take, what the agents patients take. So by history, physical examination, vital sign, and simple investigation. So by the history, we ask the patient himself, or patient, or the relative, what type agent the patient take, and then what form of the agent the patient takes, such as usually the organophosphate, the form is in liquid form, and the carbamate is usually in the powder form. And then for the after that, we need to know about the amount of patient ingested, and then the concentration of the poison. And then after we get the history, we look at the sign and symptom and vital sign to look for the syndrome analysis. And last one is the simple analysis. So for the sign and symptom and vital sign, what I said before is to look for the syndrome analysis. We have 5 major syndrome that we need to analyze in poison cases. There are consists of anticholinergic, cholinergic, opioid, sympathomimetic, and the last one is sedative hypnotic. So for the anticholinergic, it usually is the presentation is similar to sympathomimetic, except in the anticholinergic, the vowel sound is absent, while the sympathomimetic, the vowel sound is hyperresonant. And then for the skin manifestation, the anticholinergic usually patient will dry, while the sympathomimetic, the patient will has profuse sweating. Next is cholinergic. The presentation is like the organophosphate, which is patient had pinpoint, and then sweatiness. And for the opioid and sedative hypnotic, the presentations look like the same. The BP, the heart rate will come down, and also temperature. But the sedative hypnotic is no change in the pupil size. Okay, after we analyze, so we need to perform the investigations, the baseline investigations to look the evidence of target organ damage. And then for the ABG, we want to look for the oxygenation, ventilation status of the patients. For the ECG, we perform to look for any evidence of cardiovascular involvement from the poison, such as it can cause arrhythmia and also prolonged QT, as well as ischemia. So for the imaging chest X-ray, we perform the chest X-ray to look for evidence of non-cardiogenic pulmonary edema or chemical pneumonitis or aspiration pneumonia. And for the abdominal X-ray, is usually performed if patient suspected in body packer. Okay, for urine for drug, patient is a drug abuser. And then for the organophosphate poisoning, there are 2 special tests, which are serum cholinesterase and RBC cholinesterase. However, the test is not routinely done because we diagnose the patient organophosphate poisoning by clinical diagnosis. So the test is usually done for confirmation and follow-up patient, and the test is not available in most institutions. Okay, after we get the agents that patients ingested or patient had poisons, so we need to assess determine the severity of the poison. So it can start from the possible exposure, non-toxic ingestion, potential toxic, up to invariable factor. What factors determine the severity? There are 5 factors. So the first one is type of agent patient use, amount that patient ingested, the concentration of the agents, and routes of patient take, either patient ingest by GI system, inhalation, or skin absorption. And then the last one, decontamination. How early we decontaminate the patients, the poison patients. And next is specific treatment. Usually the poison, the important part is decontaminations and antidotes. Some of agents has antidote, but some has not. So for the so we need to check properly the antidotes for the respective poison agents. So for the decontaminations, so we have two types of decontamination, which are dermal decontaminations and gastric decontaminations. For dermal decontamination is we perform this copious soap and water to prevent the skin absorption to the patients. And clothing should be removed and packed appropriately, especially in medical legal issue. So, like I said before, by touching the sample of the agent also can cause secondary poison. So we need to handle this properly. And then second one is gastric decontamination. For gastric decontaminations, by giving activated shampoo. So activated shampoo usually we give 1 gram per kilo. In kids and in adult is about 50 gram to 100 gram. Which is the study showed that the presentation less than 1 hour is beneficial, but we can give up to 4 hours. And then for the gastric lavage, it's usually not done because of the risk of aspiration unless patient intubated. Okay, next, antidotes. So antidotes in the organophosphate and carbamate, we have the antidotes. So in the antidotes, what the function is to exert its action through the kinetic and dynamic interaction with poisons. So in organophosphate, we use the level 1 antidote, which is most hospital has the antidotes. Okay, what the antidotes for the organophosphate? Organophosphates are atropine and also pyridoxine. So what atropine function or mode of action of atropine in organophosphate? So we know that atropine is anticholinergic agent. So it will bind to muscarinic receptor. It can cause inhibition at the postsynaptic receptors. So it can reverse the muscarinic toxicities. However, it's no effect on nicotinic toxicity. The dose in the book is 0.6 to 1.2 mg. However, we can use with the 1 mg that usually we administer to the patient and double up the dose until the atropinization is occur. And we can give in IV if we have difficult in IV access, we can administer through intramuscular and also ETT. And the infusion should follow after initial total dose atropine bolus. So after we give the bolus of the atropine and at one time atropinization is occur, so we can continue to 24 to 40 hours for IV atropine infusion. How we administer the atropine infusion is from the total dose. My patient 60 mg total dose of atropine given, and then from 10% from the 60 mg, 1.6 mg per hour. We give the infusion over 24 to 40 hours, depends on the patient clinical manifestations. So what is the atropinizations? So atropinization are when the patient we give the atropine and we assess, we always frequent assessment to look for any clear the chest and ultrastation with no risk. Heart rate is more than 80, SPP more than 80, dry exudate and pupils no longer be point. So for my patient just now, we give atropine until the diaphoresis is clear and also the oral secretion also clear. And then at the same time, we need to look for the atropine toxicity